Let's see, it is me, you, Peter, and Regina.
Correct. Dr. Moss is here.
Dr. Moss,
Hello.
Hello, friends.
hello. I know Eileen is coming on.
Yay.
Jessica Pope just said she is not going to be able to join.
Oh,
She apologizes. Um, where am I? Eileen is joining, so we'll give her a minute to maybe get on.
mhm. There she is.
And Barbara.
Hi.
Hi,
Hello,
everyone.
everyone. So first and foremost, I'm just going to jump in just to let everybody know that we had a presentation planned for today, all things Katie Beckett, to really understand it. Unfortunately, that needs to be rescheduled for a later date due to some problems with the presentation. So that will be hopefully at our next action committee. But we did ask Eileen, wonderful Eileen, if we thought it would be good if we kind of had a conversation last week where we're taking these steps to like, okay, what would a pilot program look like? How do we get, nursing involved? And we kind of are realizing that that is like maybe a very long-term goal. But how do we start with action right now? What are the things that we're seeing that we should be, hi El, what are the things that we're seeing that maybe we can just start working with now? And I also want to go over Melissa's PowerPoint, which has put some things together. But first, Eileen, if you could give us some of your thoughts around maybe what families are going through right now that might be able to enlighten everybody, that really put a fire under my feet of how we should be moving forward.
Thanks, Tony Ann. So Tony Ann's talking about the qualitative research that I'm working on. I interviewed 8 parents. They were all moms via Zoom. And I'm analyzing the data now, but it's heart-wrenching. I'm sure, Carrie, it's not anything that is new to you. We just have outpaced the resources in the community. They're not there. So there's, actionable items between increasing the workforce, which again, our acute care providers are very well aware of the lack of coverage for families. And it's not really new news, but I think it will be able to quantify, to make a case for why we want to expand resources in the community. Um,
And Eileen, can I add one thing to that? Because and yes, like where are the resources and how do we take care of more families? And what I would like to think about also is how do we take care of more families today? Um, how do we get this education out there about concurrent care and about hospice? How do we get the education out there that I mean, from what I understand now, Connecticut Hospice is thinking about doing pediatric hospice. I have a pediatric nurse. I have nurses that are willing to do pediatric. How do we move forward right now with educate? Like, where do we go to educate? What is it that we educate? I mean, like, what is it that we're saying to people? Do we try and do liaisons in other health systems? I know there are families we could be taking on. I just don't know how do we make these things happen? Yes, Melissa.
I would say um, most is stepping back a couple of steps. I think the question is, what do we communicate? The how, there's tons of different strategies for doing it, and it's going to have to be multi-layered and multifaceted.
Mhm.
And there's no single way that gets the message out there. So there's going to have to be a fairly comprehensive approach with help from this group and probably others to get the message out there. But I think a lot of it is going to be, what are we going to say?
Mhm.
And I think also customizing the message for the different groups or organizations or individuals. For example, medical practitioners will require a different type of information because they're kind of the experts in this whole field. Whereas families may want more information about a comprehensive how do I find this, or what do I need to do? What are my next steps? And then hospice organizations may need to know, when do I get involved? What are the directional resources that are going to come to me to engage me? So I think a lot of this is, what are we going to say? Who are the audiences? And then the delivery there's a whole nother strategy around that, but I think it's having some complexity on the back end with the various individuals and organizations, and in terms of what we need to say to them, but also, how are we defining this?
Mhm. Yeah.
I guess the question goes back to, is there a world where we see palliative care being an option for kids, right? Is there a world where we see palliative care being a funded option for families, right? Because that does speak to some of the ongoing distress, is right. We talk often about how do we get families to move towards the hospice mark, but is there an option for palliative care, which has been what our most recent struggle has been, I would say, is that the only care we get is hospice care for children, but there is no palliative care for children. And I would argue some of the parents that you're speaking with may identify that need was palliative when it started much more than hospice.
Yes.
And I think, Eileen, what your study likely will reveal historical in the context is families are not only, we don't have resources that have kept up, but the needs of families have outpaced even what resources could have kept up with, meaning, food insecurity is on the rise significantly. 1 in 4 children receiving oncology care in the United States has documented food insecurity. And so that's maybe modest. They think it's closer to 50%. And so families' needs have increased. And so it's not just that it's outpaced resources we have. It's more importantly, there's new factors, is the way I see it, I think. And I often reflect on, as an oncologist, cancer used to be the hardest thing a family dealt with. Now cancer is one of many issues that families are dealing with. And this isn't necessarily hospice or palliative care driven. This is true realistic when families come and are diagnosed. There's a lot of other background noise and resource depletion that families are experiencing. And so I guess that just speaks to the importance of your research and the importance of the paucity of resources we have. The question I have is, can we look towards a palliative versus hospice model, as two entities, or are we only thinking that our state will be able to support a hospice model?
Well, and I guess that, is that more a federal question, because what we get paid for palliative care, is
Right.
like, at least with hospice, you're getting a daily rate. Palliative care, even if you were getting a decent visit rate, it might be okay. Right now, I mean, I can only go by the adult palliative care. My APRN sees them once a month and gets $24. We get $24 for that visit. So it's, how do you sustain a palliative care program unless you are funded? So like my wish list right now is, okay, regional hospice has been approved to get funding this year and next year. How can I help you? How can, like, even if it's, how can we make hospice the not so scary, just another service layered with concurrent care that doesn't mean your child has to die in 6 months, but you're going to get help and resources, and we're going to be there to pronounce when that time comes, but you can have these resources in addition. And let's trial that. Like, I can say, okay, it cost me that million that we got from the state this year. This is what we did with that million. And this is how many kids we were able to take care of. So I guess I'm struggling with, and like we also say, and I keep going back to this. And so this is, and thank you, Melissa, because this is how my brain works. I just want to do it. I just want to do it. So Melissa kind of keeps me in that, okay, well, we have to do some things first. Like, what are we going to say? What is the education going to look like? Which all obviously makes sense. So let's say we're going to have this huge elephant and we're going to take one little bite out of it, right? And I'm going to have a pediatric nurse, and I'm going to have a pediatric social worker. I'm going to have backup for my pediatric nurse. What is the education? What are the materials I need to develop? How do we go about it? And then say, okay, this small thing, or what we did with $1 million that the state gave us, can be duplicated at every other hospice, because they should be providing pediatric care if they're licensed to do hospice. It's, hospice shouldn't be an age cutoff. It's not just geriatric. How does everybody get the chance to do this at their agencies?
So Tony, and here's where I'm going to take a few steps back.
Yes.
Before we even start messaging. I think the answer is yes, but I think we need to identify where the barriers are before we start to message, because if we message that we need greater access to palliative care and or pediatric hospice care, but we don't have a workforce that we've started to build, then we've set I'm unsettled with a $24 rate. So who's going to do that if they're only going to get $24 for the visit? Because the APRN, I'm making this up, is making $150 an hour.
Right.
And you can't afford to sustain that model. So do we need to build up our problem statement before we communicate that we need more education, we need all of these issues in place, and how do we start that? But before I stop talking, I will tell you that Karen Mulvihill and I so thank you, Dr. Moss, for talking about palliative care, because I now have two babies at DPH. One is MOLST and one is palliative care. And I'm going to have a DPH contest that people get to name my babies. But palliative care, Karen Mulvihill and I are doing the report right now. And we've started the discussion with two separate carve-outs of palliative care for children and pediatric hospice. And we did a little bit of research, and we've built into the report, and Karen's still reviewing what I've done, but we referenced the Affordable Care Act that changed the payment structure for palliative care. So that, I think, could be a potential start to the discussion that we're starting messaging. But I appreciate that we have to message with MOLST anytime we get to do a presentation. If it's with 5 people, we're doing that presentation with 5 people because we informed 5 more people. But this is much more complicated than the MOLST presentation. MOLST has been operational for 10 years. So I think we need to identify the problems and maybe with a plan, an action plan, so that we don't defeat ourselves. So we have this great communication, but we don't have nurses. We don't have providers. We don't have a payment system. And again, I'm not suggesting we don't, because I like, Tony Ann, that I like action. I like to be able to check boxes off that we've done something.
Mhm.
So I appreciate that. But I think we need to understand what the gaps are and have a pathway to mitigate those to the extent possible. Sorry, I talked too much.
Al,
No,
can you
no.
talk? I think when you put together your report, you kind of followed that format of you identified the barriers, the gaps, those types of things. Can you talk a little bit about how you led that conversation to come to your conclusions? And Barbara, that's a great idea, by the way. So
Yes, I think I can speak for all of us here at Psalm Center. We're a big fan of putting together problem statements, although we also routinely run into the very important issue of just making sure we don't stay there and we keep moving, keep doing. So I think the white paper we put out was supposed to be just a piece of that elephant, just one little slice. And we tried to make it as foundational as possible, which is why we focused on coverage and we focused on workforce. And my colleagues, I think we thought that those barriers were foundational. We tried to keep it as systematic as possible, but really it was a series of iterative conversations, and we kept coming back to this idea, just kind of all roads led back to either insurance coverage or workforce. Because we did have a side conversation where we thought of, well, what happens if we focus on quality improvement first? But we thought, looking as much as you can into the extant research and studies around, is that it's really, for this particular area, because palliative care and hospice are so individualized and are meant to be, they're harder to standardize in the way that, you can kind of standardize chemo because you're like, well, there's this drug or that drug, completely oversimplifying. But point being is, we just thought that before we even get to discussions about, well, how do we make this care even better? We kept running to that barrier of like, well, who's getting it? And how do we make sure that more children get it? Because that seems like the biggest quality issue is that if you have no hospice care, no palliative care, we got to talk about that first before we're talking about making it even better, because there's just such a limited quantity of it. I realize that's all rambling now, but just to try to condense and put into separate points is in another white paper, which we're going to try to circulate, that I'm trying to finesse and work on, it's really focused on data collection. So we think that's another big barrier. And I think that's also something where we think it might be helpful because it's something that the legislature can kind of do and sign off on and it won't be terribly expensive. And so it's something that we can say, yes, we're going to do this now, and it can be done in parallel to other work. So it's not just like, well, we're just going to sit here and, kind of twiddle our thumbs and wait for this data to come in. It's more of like, this is something that can happen, and it can keep happening while we're doing other stuff. So the thing I suggested, which is really just to kind of get the conversation, another entry into the conversation, not to say this is it, this is the conclusion, is I'm a big fan of the maternal mortality review committees, just in terms of having these really intensive case reviews. But it sounds like, Eileen, like that's kind of what you're doing already. So that will get out the door. I think hopefully that will help just kind of build out, once we get more data, it'll be easier to see like what the actual foundational barriers are, on top of just in general workforce and coverage. But also I'd be interested in hearing if, again, as I keep saying, so we're not clinicians here, we're lawyers. And so if that doesn't sound right for what y'all are seeing on the ground, I'd love to hear it and make sure that what we're doing is actually supporting what all of you are doing.
For me, yes, I think that, I think that is extremely helpful. Like what you're saying and the things that we're looking at. I think that's where we left last year. We knew the barriers last year when we were working on this task force to try and figure out, okay, is it insurance? Yes. Is it staff? Is it, how do you get people trained? How do we get the word out there? So I guess for me, I feel a little stuck. So I'm trying to figure out, so what really are the next steps? And yes, data is a big thing, and trying to figure out like what are those case scenarios and where did things fail for a family. And it could be all of these things here that that I just wrote down. The fact that some people don't know. We don't know who actually does pediatric hospice, who's even doing pediatric palliative care besides, I think, Dr. Moss, your Sunshine Kids is pediatric, if I'm correct.
We're Sunflower Kids and we're exclusive. Well, we're pediatric, but I mean, we take up to 50 because we take whatever patients are seen in our community. So our oldest consult would be about a 50-year-old because that's for my congenital heart disease or advanced cancer in an adult, but primarily pediatric.
Okay. So for me, I guess, after different conversations, you kind of shift this way and then you come back together and it's like, now you shift this way. And then, you have a meeting and you find yourself over here. But I guess we're back to being able to provide something in February that is, I guess would be the education that we would want to give to out to the state providers. We talked about potentially the coalition being a avenue for information or resource if things lived on the coalition website. Trying to make changes with palliative care reimbursement. I mean, it's a joke, but if they're not going to change rates for palliative care, how do we use hospice as a vehicle, and it not be hospice, where it's the thinking of the 6 months and the maybe we try and get the 6-month criteria, since we have concurrent care, changed for pediatrics. I mean, that would be the biggest thing. I see Elle shaking her head, so I love that, and what does that avenue look like? Is that something that we can even recommend on the state level? That, that's a federal request, but, do we say that if that changed and we called it champion care, like, we left the last session of the task force with that going forward in that direction, then I think that's where we are. And maybe our to-dos are, what does the curriculum look like for a pediatric nurse in hospice? What does it look like for insurance coverage, at least in the state of Connecticut, and Medicaid rates for palliative, or changing the criteria for hospice and letting us call it champion care. So those are my thoughts right now. And maybe in tandem, while we're doing all this work and trying to get that recommendation ready and what everything is going to look like in that recommendation and how to do it, in tandem, I'm trying as an individual agency to move forward and see how it would be for us to start educating and getting out to providers and doing things like that, how we're able to move forward with what we have already.
So are we looking at champion care as the state, that would be the nomenclature that we would use for the state to identify pediatric care, correct? This is not just regional hospice. In that case, we'd adopt it kind of for statewide pediatric palliative / hospice care.
Right.
And so in doing, I mean, I think you've already hit on other points, and I think it will come together nicely. The thought, I mean, what we're talking about is changing the narrative, right? What we're really talking about is changing the narrative of how we view hospice care for children in our state, to provide them with resources that they can't otherwise obtain. Because we're not going to change the palliative care. And I think I asked that question almost rhetorically of like, if that doesn't change, then how do we really get these? Because the patients, I think that Eileen is going to identify, the resources that families need is not, although pronouncement is incredibly important to me to avoid parents returning to the hospital, that is not their first concern of what their needs are, right? Their first concern is long before that, as we know. It's the relationship, it's having someone in the house helping make decisions about both directions of care and management of symptoms and all of those things. And that is truly as much palliative as it would be hospice, right? It's really a vernacular of what we call it, but we really need to change the narrative so people understand what we're trying to do is provide resources for children that may portend towards end of life, but may just be in the moment until they graduate from hospice, which we know people can do. And that is, I think, using a different name, right? We are Sunflower Kids, not because we were trying to hide that we were the palliative care team, but because we wanted an identification that didn't remind people every time they said it that their child might be not doing as well as they hoped, right? So maintaining hope through a name change really does work for people, because people don't want to be part of the Connecticut Children's Hospice team, but they kind of like being part of the Connecticut Children's Sunflower Kids team, right? And so really, if we're looking at changing the name, we then need to change the narrative that goes with it. And that, I think, when you think about the timeline we have, what about coming together with, what about thinking about how we brand that, how you put that together, how that becomes a video statement that can go out to different places? How does that become something that people will recognize and understand that this is what we're moving towards in our state?
So, those are all like absolutely perfect points, Dr. Moss. I mean, like, I think you're reading everybody's mind too, but I think there's ways you can do that effectively. And I had mentioned to Tony and an external resource maybe to take a stab at helping us do that, because it's complicated, it's elegant, it's technologically sophisticated. I don't know about the rest of you, but I don't have those skills. I could do some writing, but I think we probably need to look at resources to help us shape the narrative, because that's going to be what sells this footprint, this approach to helping our patients and their families. And I think that's absolutely critical to getting everybody on board. And in theory, that will cover all the different providers or audiences that we need to touch. Including, maybe some technology solutions, website stuff, interactive engagement with families that they typically use, assuming that this age group of parents are somewhere anywhere between like 20 and 35 or 40 years old, who use technology as their basis for a lot of decision making and engagement and things. So I think there's opportunities out there to do something impactful. I think on our side, all of you hold the expertise to say this is what we should have and this is why. And then the messaging can be outsourced to others who have that competency. So I don't know, Barbara, you had your hands up.
I just have a question, because as we prime ourselves for the next legislative session, and I know I've heard that February we'll have a submission for a report. Right. But if we're thinking that we need, and again, I appreciate the changing the narrative, rebranding what this actually is, and is there money associated with this that the legislature or are there appropriations that would be needed to move forward with this work? And I think the answer is yes, because as Melissa has indicated, Melissa's brilliant, but she's not an IT consultant.
Go on.
if we needed supports like that, then it would require an ask of the legislature. We'd want to start that discussion now, sooner rather than later, because this is a short session.
Right.
Eileen?
And I appreciate everything that has been said. What I've heard from many of the parents is that Medicaid is providing more resources than private insurance. And that Community First has been a wonderful resource. And some of the moms are they're appreciative that they qualify for Community First and Medicaid in comparison to so many others that can't get help. So how do we bridge that financially? How will Champion Connecticut bridge payment, the payer source? That's where I'm stuck. I don't worry about the education at all. I'm happy to work on this with a team of people. I just, through the growth of the coalition, I know how many passionate people will step forward and create something. I'm really not worried about the workforce, although I know it'll be major. I should worry, but I feel that's more tangible. It's payment that I'm stuck on.
So, yeah, and I think that that's one of the things too, right, with Katie Beckett. So it's people that don't qualify for Medicaid, but can't afford other services. So they go on the Katie Beckett to be able to get Medicaid, and there's a 300-person wait list. So how does that, how would that work? So that's a good question. And I see Elle with her hand up, and then Barb. Go ahead, Elle.
Just super fast. Yeah, so Katie Beckett, on that, just two things to put out there in the ether, building off a little bit what we did in the white paper, is currently Connecticut has their Katie Beckett set up as a waiver. There's another option where it can become a state plan amendment, and what that generally means is that there's no cap. So there's still funding issues, but that potentially could be, that's a big pie in the sky option. Also, another option is there are other ways to structure waivers. And so Connecticut could look into different Medicaid waivers that could also make it possible for other families to get care. So that would be a Katie Beckett-like waiver, but it would open up another funding stream for families, and because waivers allow states to modify who's eligible for Medicaid. But that's also kind of pending what's going on at the federal level. So that's kind of bucket number one, options. Bucket number two, something we have been talking about here is doing more research on legislation that would actually require private insurers to cover some sort of palliative care. And that would be structured as a mandate. Other states have done that, like California's done that for a couple options, different types of care. And so that's also something that, would cost the state money just in time and resources, but also wouldn't require necessarily an outlay and may also help bridge that gap. So kind of options are playing around with Medicaid, including Katie Beckett, playing around with Katie Beckett, or doing Katie Beckett-like waivers in a different program, which other states have done as well, or looking at a private insurance mandate, which would be legislation.
That's great info, Barb.
So thank you, Elle, for that last comment about the mandate with private insurance. We've done it in other areas with healthcare. It's not an easy lift, but if you have buy-in from the Public Health Committee, we have two great chairs in Connecticut. I think it's important to communicate with them sooner rather than later. And the other point I was going to make is, do we need to have the payers in one of our meetings? I hear, Eileen, I'm so happy to hear that individuals who are Medicaid beneficiaries, and Regina, not because you're on the call, but we have a tremendous Medicaid program in Connecticut. Our colleagues at the State Medicaid Agency have done great work for Connecticut. But we still have a way to go. We're not perfect, but the private insurers have not kept pace with that. And I've been on other work groups where we have had payers come to some of the meetings to hear the challenges and get their thoughts about what can we do to help get support. Can't do this care without money.
And I completely agree with you there. I just don't know. I have a contact at, I think it's United. I'm not sure, but I don't really have any other contacts for payers. I would love nothing more than to, be able to, pull them in or have the discussion, because I mean, and I agree with you. Medicaid, to be honest, from a hospice perspective, is not the problem. It's the private insurers or the people that can't get on Medicaid. The private insurers don't even come close at times to the Medicare rate for hospice for adults. So it is the private insurers. Is it that we have a conversation or pull them in, and that can help the conversation? Or like, is it that a recommendation going forward is that we're going to have to leave it to the state to do, to maybe help with some kind of mandate that if you want to be a provider in the state of Connecticut, you need to have a pediatric hospice benefit. Some don't even have that. And B, if you do, it has to be at least the equivalent of Medicaid.
Tony Ann, I have a contact with insurance, but let me pull some information together that I can share with you and Dr. Moss.
Okay.
And maybe they could provide some additional information.
Okay, that would be great.
And Eileen, can I just ask one follow-up question? Of the 8 moms that you spoke to, is the majority of the payer, were they Husky beneficiaries, the majority of them, or they were?
Yes. Off the top of my head.
Sometimes the circumstances surrounding a chronic illness just drive you to that benefit for a variety of reasons that we all know of.
Most
So
of
I
our
will
patients have Husky B as like a follow-up, right? Most of the oncology patients meet their deductible like in a moment, and then families end up many of them end up with Husky as part of their payer contract. And it's easier to get everything approved. Everything's easier in Husky. Everything.
Regina, let Bill Halsey know everyone is very happy with Medicaid.
And Al, the white paper made a few recommendations for in looking at other states and a best fit for Connecticut. That's where, again, I get stuck on. So out of those 3 choices, not that anyone has a crystal ball, but what would be the most beneficial to go after? Or most likely to have success?
So I will add that another avenue we're pursuing is we are trying to get more information from Massachusetts, like really detailed information about how they're structuring their program, which is called the Palliative Care Network. So they didn't have a name change, which we're asking about as well. But that program, I think I've been familiar with, is a pair of last resort program done with hospice partners. So as we're trying to figure out how that would go, because that's entirely state funded. Particularly right now, we thought it might be useful because it's not directly dependent on any kind of funding from the federal government. It's not a Title V program, so we're not even getting a direct block grant. We're not entirely sure exactly the funding works, but we think it's just from general appropriations. And as far as expenses go at the state level, it's fairly inexpensive for the number of children it serves. So we're cautiously optimistic about something like that in this particular moment. We're also trying to get more information about the experiences of states who have gone for an expansion of Medicaid through a waiver or through a more permanent state plan amendment. And usually those are done in conjunction with something more just larger. So either palliative care for adults and peds, either just community-based services, again, for everyone. So those have been bigger. As we discussed, we're looking into that. The only other last thing I'd like to add is that this is a bit out of left field, but one more thing that I'm looking at and working with my colleagues on is some of my research focusing on private equity and private equity acquisitions of various healthcare providers, including hospices. And so there's been some movement at the state level and a little bit at the federal level to address fraud for some, bad actors who own hospices and who own other healthcare providers, trying to make, cut staff, cut resources, and try to get that money from Medicare, Medicaid. And so I think there's been a little bit of movement of just actually increasing access through something like that, like oddly enough, like addressing fraud or just trying to use an opportunity to reshape benefits and reshape the relationships between private payers and healthcare providers. So that's like very much a stay tuned, but it might be another addition on, is just trying to find weird vehicles to get to our objectives that aren't necessarily like increase palliative care access for peds. It's like, make it harder for private equity to purchase a hospice. And by the way, this also helps, with the funding issue. So it's another like off to the side thing we're doing in the background. I think in the foreground is really more of just like talking with payers and trying to see if there's any way to finagle Medicaid.
Thank you.
Can I just ask a level set question? And this, you don't have to answer it now, but we've talked about doing more or less a phased approach, potentially because we want to test the footprint and make sure we get it right before we become more expansive, right? Do we need to have defined our model, our mechanisms, payer sources? Do we need to define everything in advance of the February 6th report out? Or are we just putting forward a proposal? Here's what we would define as the model of what we want to use. Here's a comparative view of what it would cost with and without concurrent care, how we think things should flow. Here's how we would expect to brand and deliver education about this, how we would expect to expand the number of resources, skilled resources out there, et cetera, et cetera. So the question is, do we walk into our February 6th report with a model? Does it have to be comprehensive now as a model? Or are we just going to put forward the challenge of here's what we're thinking? And then after that, assuming we have a continuance, work on smoothing it out over the ensuing 6 months or something for another year of putting things into motion. And so I guess just a thought, and it would be helpful to try and figure this out and make sure we know what we're moving towards for the February 6th proposal.
Well, I from my perspective, and then of course, let's, hear from Dr. Moss, but from my perspective, the more concrete we can give by February, the better. We kind of gave a recommendation, and then we're given more time to then kind of put this thing together. So I'm thinking the more concrete, the better. Of course, we're going to need some help along the way. So even though it might be, well, we're going to say about private insurers, I don't think that's a lift for us. I think that's going to have to be that we then put in the hands of, I don't know, the Public Health Committee, appropriate, like, I'm not sure where that goes next. But I think the more concrete of what needs to happen would be better. Still with, if there's things that have to be done over the next time frame, after February, that would be good. But like Barb, you happened to mention, if we were thinking about something, and I can't remember which thing it was, we should let appropriations know sooner than later. So like sooner than the February report or in the February report, like I'm not like, I'm just trying to figure out the timing on certain things.
Peter may be able to help support this as well, Tony Ann, but I think if there is going to be a need for appropriations, money to support this program, I think you'd want to give the two public health chairs a signal to the extent possible beforehand, before the February 6th date, that we are proposing whatever ABC, and we are anticipating that this will require support from the state for funding. And whatever that looks like in whatever pathway it looks like. But it gives them an early signal that we want to do this, but more importantly, we need to do this because we have over 7,000 children that are suffering with a chronic illness. And a large majority of them can't access the totality of the services that they need.
And I guess part of that too, where maybe L comes in, you know, the Solomon Center, I'm not sure, is how do we back up that statement, right? We have 7,000 kids with chronic illnesses. Okay, how many chronic illnesses? What are the chronic illnesses? You know, how many in each cat like that we can back up the information of here are all the kids that are in need of this program, which I don't really think that they're fighting that there's not a need, but the more we can show it, the better. How many kids are on Medicaid? How many are on, you know, private insurance? I think that all of that data would, you know, would help the cause also going forward. But Dr. Moss, what are your thoughts?
So I think I like where we're going. The one thing I think would be nice if the report were divided into this is what we can do with what we've realized in realizing what we have as a state, what resources are out there. This is what we can do with what we have, right? So to recognize what we're already doing and what we have capacity for in this moment. And capacity may be support of the coalition. Capacity may be that regional hospice can provide to a certain area of the store. But what is our capacity in this moment? And what have we come together to recognize is where we are in our state? And so it's not as much just a report of what we have in our state, but what we can do with what we have. And then the next step is, in order to provide what we see as service excellence or what we see as standard of care in other states, this is what we need. So that the first part focuses on what we're already doing and what we can do with what we have. And the second part focuses on how we could become much more. And that really speaks to the center of excellence. That really speaks to the steps that goes with that. And I do think, I mean, if you think about it, like, and I don't know why this is dawning on me today about a rebranding, like if we really are in the measure of hospice being where it's at, right, that we need to do this through hospice, then we need to be able, the two big pieces are going to be meet the requirement that some of these in terms of the life expectancy, and two is get parents to buy in, right? We need buy-in, and the buy-in is going to come from the rebranding or the change in the narrative, as I was speaking to before. And how do you do that? Well, you develop a program that says this is our champion program, and then you go to grand rounds and you introduce it, and you go to hospitals and you introduce it, and you say, we want to introduce you to the way we are going to look at that palliative and hospice care for children in Connecticut moving forward, based on the support of our legislature. This is what we're doing now, and this is what we're proposing to do in the future. This is what we're hoping to get to. But this is where we are, and instead of being unabashedly sad about where we are, just being proud of what we have and what we can do with what we have, and then state, well, but if we're really going to be a state of excellence in providing this care, this is what we need to do that. So I think if we could put that all together. I'm sorry. I think if we could really get that together, that would be enough to submit in February.
So to your point about rebranding, in my former life, we had developed and launched a very comprehensive program that impacted almost 6,000 individuals, leaders in my firm. We did road shows across 50 offices. We did an online website. We had interactive subject matter experts. We had a decision tree, so we could go in and find something because if this, then that. We had a kind of a library of resources. We had external firms. All this is coordinated by probably a little team of about 15 people, but obviously all paid by the same employers. We all had the same commitment, but it was very effective. We still continued, even when I left, to have questions about where do I find this? But the impact of an expansive rebranding and communication strategy was pretty effective. And it did require a lot of hands-on approach, but also folks like yourself being able to pass along the message and clarifying to your patients or your colleagues or your networks, this is how this works. So there's a lot of hands-on, but that goes back to my early statement of there's no single way to get the message across. There's lots of different ways, but we do need to change the name and change the messaging so that it's acceptable to the people we want to support.
And if it ultimately connects to the Connecticut like to the DPH websites, to the websites that when you Google pediatric palliative care and hospice in Connecticut,
Yes.
you come to this this is a resource choice. And that resource choice then provides you all of provides you the links to, the coalition. So when I educated the Yale Hospice Fellows last week and spent a day doing didactics for them, one of my slides talks about Courageous Parents. One of my slides talks about Eileen's work and how amazing the coalition is. We're pushing those resources to people and showing what we have. I think that that's really where the impact is to not inflate what we're doing, but share what we're doing.
Right.
And then share where we could really make this the next, like what we really want to, instead of saying we demand it, say this is where we want to be provide excellent care for children, dying children, no less. Then this is how we get there. And this is what we need to do it. And then separately, we have the champion program that's kind of growing out of the funding you have, Tony, and where we're seeing, we're really using this rebranding to see what we can do with those kids. But from a government or from a legislative standpoint, I think we need to be clear where we are and where we can go with the appropriate support. Because I think we're doing more than people think. I think we're doing more than we think, right? Like I always step back and go, wow, look where we are versus where we were when I came to Connecticut Children's 15 years ago, and people couldn't even say, I had to be called the advanced cancer care team because palliative care was too hard, right? So see where we are 15 years later, it's pretty remarkable. So even just some of the getting out and branding what we're doing is like probably something we haven't fully done, like as a group to do it. I don't know if this is resonating with anyone, but I'm thinking in the time period we want to move mountains, and Tony Ann and I might not be the best match on that because we're ready to storm the castle always. But maybe maybe we're storming the castle in a different way by getting this all set up.
Yeah, and that's probably like just where, I'm at and what I needed to hear. Like, I feel like, my God, we're not doing enough. Like, like, why do I feel so stuck, and why aren't we going faster, and, blah, blah, blah. So that was good to hear that. And you've been doing it for so long, whereas this hasn't been this has not been where my career was for so many years, but only like the past 4 or 5. So I'm like, my God, are we really doing anything? And you're right. Storm the castle and move the mountains. That's where, I go sometimes. But Melissa's been doing a pretty good job of reeling me back and saying, okay, hang on, hang on. We need to, do ABC first. So.
Right.
So what would we say? Like,
Eileen has a comments.
Oh, I'm sorry. Go ahead.
Question.
I'm part of the STORM team. Carrie, I think that was beautifully said. I like mapping out a proposal. Here's where we're at. Here's where we want to go. I still don't understand how we're paying for where we want to go. And I thought that this group, part of the task force issue was what would we advise for a model going forward?
So Eileen, to that question, how do we dig deeper into the data, into the numbers, both from payer sources and as well the costs? Because I think that's a big piece of the story we have to push forward. Absolutely to you. And I think Elle is tackling some of this too with their reporting. But how do we get that done? Because that will be a big piece of what we put forward.
From today, and I'm just brainstorming, from today, could we call together any data from the Community First families? What their expenses are, how are they utilizing Medicaid dollars? I mean, I'm hearing extraordinary stories, like we can only get one chair, and yet we need a bath chair, we need a toilet chair, we need a chair to our child to sit at the table. But we can't get that. And we look at Facebook Market, and we had people looking for us all over the state. And my child needs to sit. I mean, the stories are desperate in some cases. So if Community First is offering relief, financial, alleviating some of the financial barriers, financial constraints, could we compare it to someone who's dealing with private insurance? Would that support a case of where we want to go?
Oh, any thoughts, Eileen, about how we'd access? I don't know if the Department of Insurance would be helpful. I can kind of poke at that to see, but I will openly say I'm willing to look, but I am not an expert. Maybe Elle, you have better pathways, or you've collected remarkable information from the white paper. So I don't know if you have access to anything.
I think we run up into a lot of barriers, just because we aren't a public center. But that being said, I don't know. I can definitely try to ask around the school, because there are a number of professors and researchers here who aren't necessarily focusing on palliative care, or even healthcare, but are focusing on government and government payment, taxation, and some of those people might have a better sense of what databases are available. And we have a lovely library as well. So at bare minimum, I can run this past our library and just make sure that they know. I don't know where they get their magical knowledge of everything, but they have magical knowledge of everything. So that's what I'll make myself a note, and I could do this week, and I could try to share if I find out anything useful in terms of extra data sources. My sense is that we probably have to poke some government agency or another, and they may not want to share it, but maybe state FOIA, a state, Freedom of Information Act might help too.
I'll check with insurance, and I'll also check, and I'm just grasping at straws now, if OHS, the Office of Health Strategy, collects anything. They collect tons of data. So I don't know if this is a metric or not, but I'll see what I can find.
Barbara, one simple question I have: why is a family whose child has a fresh gastrostomy tube going home without any home care visit?
And who's the payer? Is it private insurance?
It's private insurance.
Okay.
There's no home care nursing.
So that may be healthcare advocate as well. I don't know the answer to that question, Eileen.
I was floored.
As a nurse, am I outraged? Yes. And give them my name and I'll do a visit. But I can't explain it. It would just seem to me, that it's a standard of care.
Right. We've lost something.
And while I want to presume that teaching is done in the hospital, the hospital setting is very different from the community setting.
This is a mom's report. So they receive 10 minutes of teaching, this day surgery, and they're off. They go home. They find the equipment delivered to the doorstep via FedEx. So it's not even set up. They're overwhelmed that their child now has a gastrostomy tube plus other chronic conditions, and they have to figure this out all alone. in their home without any nursing. And call us if you have questions. It should be the opposite, where we're
And
going to
the
do a follow-up
referral-
check with you in the morning, and it's not. It's here's our number if anything comes up.
And a referral has been made to a home care agency or no? Or
The
insurance would not
moms
approve it?
who had private insurance said they didn't qualify for a home care visit. And this is just one example.
One of the positions, and I could be very simplistic about it because I don't do what you do, but the thought of having each patient who's part of this program has a case manager, someone with expertise who will track, follow, advocate for, navigate all the needs of the kid, and that
would be one
the
of my
handoffs
recommendations. Yeah.
between
Yeah.
the different facilities or different providers, that
And-
would
and I
become
don't-
part of the plan.
Yeah.
Yeah, I don't want, but Peter has his hand up and I'm sure he's going to tell us
Oh,
it's
we have to get off.
2:01.
Yeah, sorry.
Thank you so much, everyone.
All
That's
right,
okay.
see you soon.
Thanks.
Thanks, everyone. We'll send out the.
More to come.
Okay, thank you.
Okay.
We're gonna get there,
Bye-bye.
guys. We're gonna get there. I promise.
Okay.
We're gonna get there.
All right.
We're
Bye.
gonna get there.